start the presentation. So thank you, listener, for the kind introduction. Certainly, there's the first step to doing presentations. Make sure that there's some technical difficulties and then send the host a long bio sketch with irrelevant details, because then you don't have to actually talk so long. On that note, though, this meeting would have been a whole lot more enjoyable if we were able to do it face-to-face. Of course, with COVID and a lot of changes in the digital, we now do it on a virtual platform, which also comes with its own advantages. I could be doing this presentation in my pajama trunks and nobody would even know. Although, just for the record, I do have my formal work attire on out of the greatest respect for all of the audience. On a more serious note, though, this evening's topic, I hope to give you at least a little bit of insight and understanding into where things have come from and where things have been going in terms of the classification of breast carcinoma. And certainly, it's very difficult to pitch a presentation when you've got a mixed audience, because I know that we, for example, do have some general practitioners, we have histopathologists, we've got a smattering of clinical colleagues like surgeons, oncologists. There are also professional or registered nurses, medical technologists. So I've tried to make the presentation as basic as possible and perhaps embellish it a little bit with more detail where it's relevant, specifically on the pathology front. I think that everyone is very well aware of the fact that breast carcinoma is a huge problem worldwide. It remains the commonest non-dermatological cancer of women. And in very high incidence, high income countries, the lifetime risk of a woman developing breast cancer is somewhere in the vicinity of about 1 in 8. Cumulative lifetime risk. Interestingly, the 2020 cancer statistics actually place Belgium as #1 in the world, with an age standardized incidence rate of about 113 per 100,000 population. The second on the list is the Netherlands, with the US, I think, about 10th on the list, with an ASR of about 93 per 100,000 population. In South Africa, we've got statistics from 2020 from the National to some extent unreliable, but it does definitely reflect the very striking dichotomy that we have in terms of the racial distribution of breast cancer. The commonest, of course, is amongst white females, where the lifetime risk is about 1 in 12, all the way through to the indigenous African population, where a woman's lifetime risk is in the vicinity of about 1 in 51. So certainly a worldwide problem. In South Africa, also a huge problem, and a tumor that continues to cause considerable morbidity and mortality. So in the next 45 minutes or so, we're going to look at a number of different points with respect to the classification of breast carcinoma. We're going to kick off with a little bit of background as to why we classify breast cancer, or any cancer for that purpose, morphologic classifications, how they started and where we are today, and then move on briefly to receptor and biomarker-based classifications, then on to the pathogenetic classifications, and then finally close with some molecular classifications. So let's start then with why we classify breast carcinoma. And the main reason for that is because we want to have a reproducible pathologic diagnosis, whether we diagnose it in Pretoria, Johannesburg, Cape Town, Cairo, London, or New York. We want all of the pathologists to speak the same language and to call the same things by the same name. And directly coupled to this, obviously, is the fact that this then predicts the expected biologic behavior, clinical associations, and prognosis associated with a cancer. So if somebody is diagnosed with an invasive lobular carcinoma, one automatically knows that they have a much higher risk for not only multicentric disease in the same breast, but also bilateral disease. The third reason, of course, is to facilitate optimal therapy. So by knowing what type of tumor you're dealing with is going to determine how you are going to approach it from a therapeutic point of view. There are a few more reasons that I have listed at the bottom there, although I'm not going to leave them on for too long. And certainly, if anyone quotes me on these, I'm going to take the Fifth Amendment or do what Bill Clinton did, and that is deny, deny, deny. I think one overriding fact that's come out of all of the changes in the different classifications is that breast cancer is a heterogeneous disease. It's not really different faces that arise from the breast of a common tumor as much as it is many diseases involving the same site. And I think one large shift has come with the understanding that previously where from a pathology perspective, we believed that different breast cancers arose from different cell types in the breast and were therefore subtyped or typed based on their morphologic appearance. So we had ductal carcinoma, lobular carcinoma. We now know with various molecular studies and research at a molecular level that breast cancers arise from common stem cells, and then due to various molecular events or mutations, differentiate in various directions, which then leads to the phenotype that we see under the microscope. Sadly for the pathologists, histological subtypes are playing an ever decreasing role in the prognostication and therapy of breast cancer. And whilst it is very enjoyable to be able to call a tumor a specific subtype and it slots perfectly into that category, if it doesn't really make any prognostic or therapeutic difference, it just remains an academic exercise. And in 2023, certainly prognosis and the response to therapy and the tailoring of the therapy relies on a combination of factors. And on a histologic front, that includes mainly the tumor grade, the tumor stage, of course, the biomarker status as we determine it in the laboratory, and then more recently, additional molecular findings as well. So let's then go and have a brief look at the morphologic classification of breast carcinoma, and certainly already at a macroscopic level, if one looks at this breast cancer taken out of the WHO Blue Book, you can appreciate that this is malignant. And the tumor that you can see here has all of the characteristic features. It's got an irregular outline. It's got this pink to gray-white hue, and as you can see, the tumor in the middle is standing up as opposed to all of the tissue around it that sort of has sunken in, and that of course is because of the fact that it has a very fibrotic or sclerotic stroma, which is very often likened to that of an unripe pear on sectioning, which is only a term, of course, that a pathologist could coin. It would probably come as no surprise that the ancient Egyptians were already experimenting with classifying breast lumps and knew very well that there was a group of these that had a relatively indolent and favorable course, which were, of course, the inflammatory masses and things like a breast abscess, and others that were more ominous in terms of their clinical and biological course, and those were, of course, the breast cancers. So this is a whole mount section of a breast cancer taken again out of the WHO book. And again, you can see the irregular outline mirrored microscopically, where the term cancer, or as it was originally called in the Greek karkinos, and is cancer, of course, is derived from the original Latin word for a crab and is ascribed to Hippocrates as coining it. The reason for that being that the periphery of the tumor with all of the invasive little legs that stretch out were likened to the legs of a crab. In the Middle Ages, in fact, when people started to observe the tumors, for example, in the skin, there was also the association with a crab because of the radiating venous blood vessels that were seen at the periphery of the tumor. As you can see in this whole mount section as well, there's a very, very pink fibrotic area in the middle of the tumor, and this usually we see as pathologists either in a patient who's received neoadjuvant therapy, or if it's in a de novo tumor, it definitely portends a poorer prognosis. So the microscopic classification of breast cancer really started with the invention of the microscope, and the credit for that goes to Anthony van Leeuwenhoek, of course, who invented the first microscope, although that is maybe a little bit of a misnomer, because all that it was actually a giant hand lens. It only had a single lens in it, although very high quality for the time. But with this, Anthony van Leeuwenhoek was in fact the first person to describe what he called diertjes in Dutch, which translates into animal cules. He has also has the notorious distinction of being the first person to document Giardia parasites in his own stool. I think on a more romantic note, one can briefly look at the background and history of where the hematoxylin and eosin stain comes from, that we as pathologists use on a daily basis, and is really the staple of everything that we do under the microscope, classification of breast cancer and any other tumor and any other examination that we do. So hematoxylin, which is the blue stain that you see in the slide, is actually a basic compound and is therefore attracted by acids, which are mainly concentrated in the nucleus, which is why the nuclei are stained blue. The eosin, which is an acidic compound, of course, is attracted to the amino groups, which are very abundant in proteins and therefore mainly stain the cytoplasm of a cell. So the origin of the H&E stain actually wouldn't be remiss as a Netflix miniseries. Hematoxylin was first discovered in the 1500s by the Spanish conquistadors when they were busy exploring the New World, which turned out to be Central and then later South America. And one thing that they noticed was that the indigenous people were boiling a specific type of tree, a logwood tree, to extract a very striking crimson pigment that was present. And this, of course, was brought back to Europe and eventually started an economic race between England and Spain, because this was then a very hot commodity. It was being used to dye textiles and material, and in fact there were even stories of buccaneers and pirates hijacking ships at sea with logwood, whose generic name incidentally is hematoxylin, which is where the name for the stain comes. It was used in histologic sections in 1800 by a chap by the name of Wilhelm Gottfried Waldeyer, and he noted that it actually gave quite a pleasing stain to the nuclei and the axons in neural tissue. So fast forward a little bit to the 1800s, eosin certainly had a much more romantic and scientific beginning, being developed by the German chemist Heinrich Caro, together with Adolf von Baeyer. They found that by bromination of fluorescein in alcohol, you developed a very, very pleasing and striking pink, red to orange pigment, which was actually tetrabromofluorescein, although that's a bit of a jawbreaker name. So they quickly renamed it eosin, Eos, after the Greek goddess of dawn. And as it turns out, Eos was also the nickname of one of Heinrich Caro's childhood flames. This pigment, of course, was all the rage in Europe at the time, being used in everything from dyeing clothes to lipstick to being included in lake, which was a pigment and a compound put into paint, and was actually sold to some painters, including the very well-known expressionist painter Vincent van Gogh, who in one of his paintings included geranium lake, as it was known. Irises in the Field of Arles is the name of the painting, and the rest, of course, is documented in history. The combination of hematoxylin and eosin was first tried out by a microscopist by the name of Wazowski in 1877, and as part of his study on hemoglobin in embryonic tissues, he actually penned a line in the paper where he said, "This fact promises widespread application in the future." And of course, that was incredibly prophetic, because everything these days is done on the basis of H and E morphology. So let's move on to the systematic classification of breast tumors under the microscope. In 1956, the World Health Organization convened a group of international experts and made editor-in-chief of the first series of the so-called WHO Blue Books was the internationally renowned pathologist who was working at the Armed Forces Institute of Pathology, which was Leslie Sobin. And they then set about, much in the vein of what the Armed Forces fascicles had started to do, although on a much more international front, of classifying tumors. And the first series of the WHO Blue Books, which came out in 1962 and were published all the way through to 1980, then went and classified approximately 300 different tumors from 15 different systems in these guides or blue books that the WHO then published. Needless to say that we've come quite a way since then, and we're in the 5th series at the moment that you see reflected there. And this is the current 5th series 2019 WHO classification of breast carcinoma and other breast tumors. So the first thing that you'll notice right at the top is that it is now called invasive breast carcinoma of no special type, replacing the previous terminology, which was invasive ductal carcinoma. The reason for that I alluded to earlier, because of the newer understandings in the histogenesis of the breast cancers, as well as the fact that most of the breast cancers are of ductal phenotype. And therefore, it's pointless just saying ductal all the time. Just call it an invasive breast carcinoma. And if it is a specific subtype, as you see there, or specific histologic variant, then you need to specify it. The second paragraph that you see there are the rare and salivary gland type tumors. And you'll see that there are a couple of salivary gland entities there because of the similarity between the breast and the salivary gland. And on this note, I have to put in a very quick plug for next Tuesday's Breast Cancer Forum here in Pretoria, Tuesday evening, starting at 6:30, where one of my very esteemed, erudite and enthusiastic young colleagues, Dr. Elsa Elof, will be taking part in the discussion and also presenting on some of these very rare but very unique entities. So if we move on to the main differences from a histologic perspective with respect to the 2012, which was the 4th edition of the WHO classification, and the current one, you'll see that there are a whole host of changes that came about on the histologic front, which have been highlighted there. The whole concept of mitotic counts has really been changed across the board in many tumor types, from neuroendocrine tumors through to counting mitoses in smooth muscle tumors of the uterus and gastrointestinal tumors, etc. And the main reason for that is expressing something as per 10 high power fields is really incredibly variable, as different microscopes have different surface areas for a high power magnification at 40 times objective, and working out the surface area and standardizing it per square millimeter is obviously much more scientific and reproducible. Medullary carcinoma, we're going to have a look at in a brief moment. Those very unusual histologic subtypes we're going to address very briefly as well. Important to note for the histopathologist is that lobular carcinoma in situ has gained an extra histologic variant, and that's the florid type. Important to note as well, I think across the board, is the fact that lobular carcinoma in situ, of course, is no longer considered a precursor condition for breast carcinoma, but merely a risk factor that indicates an increased risk for developing subsequent breast carcinoma, and that risk actually translates to both breasts, not just the one where the LCIS is found. Neuroendocrine differentiation and neoplasms, we're going to have a look in a brief moment. There is one change that was made pertaining to the diagnosis of phyllodes tumors with respect to well-differentiated liposarcoma. The histologist would be very well aware of that. The next 2 points there we're going to briefly look at. Those are two new entities that have been included. The periductal stromal tumor has really just been lumped back into a variant of phyllodes, and as out earlier, there are other tumors that are rarer and also of mesenchymal hematolymphoid origin, and this, together with genetic tumor syndromes, have their own dedicated chapters in this new WHO Blue Book. As distinct clinical presentations of a specific type of carcinoma. So let's have a look at the tumor entities that were omitted from the 5th series classification, and they are listed there. The main reason, of course, being that these tumor types do not on their own have any specific prognostic or predictive implications. And from a pathologist's perspective, certainly it is a good idea to include these in your report, whilst maybe not putting it down in the diagnosis, specifically if the tumor is to come back or metastasize, because seeing a clear cell carcinoma in the lung would certainly raise a very broad differential, top of which, or at least near the top, would be clear cell carcinoma of the kidney. Knowing that the patient had a clear cell tumor of the breast would, of course, alert the pathologist to be more directed in terms of how he investigates the case. Medullary carcinoma as an entity that we all learned about at medical school has also been dropped as a specific tumor type, and the reason for that being the fact that, first of all, it's a diagnosis that has very poor inter-observer reproducibility. I remember when I was training as a registrar, one had very strict criteria, and you looked for 5 different aspects of whether you could call this a medullary carcinoma or not. If it fell short, it would be called atypical medullary carcinoma, or maybe just invasive ductal carcinoma with medullary features. We now know, of course, that these tumors actually have features that overlap with your so-called basal-like molecular profile, and many tumors actually have BRCA1 mutations, and the paradoxically good outcome of these relatively ugly tumors under the microscope is explained by the fact that they are exquisitely rich in tumor-infiltrating lymphocytes, and that, of course, is a good prognostic sign, because that usually indicates that there are a lot of molecular abnormalities and tumor mutations in the tumor. So currently the preferred term for medullary carcinoma is invasive breast carcinoma of no special type with medullary pattern, understanding that this represents one end of the spectrum of a so-called TIL-rich, tumor-infiltrating lymphocyte-rich invasive breast cancer. The neuroendocrine neoplasm controversy, I don't want to say too much about. Primary small cell neuroendocrine carcinomas of the breast are exceedingly rare. And certainly if you do see one, like at the bottom of the slide, where it's stipulated that you always need to exclude the possibility of a secondary tumor, possibly from the lung or elsewhere. And more indolent group of these tumors are even rarer still, and certainly they do have a characteristic morphology and behavior, but whether there is a primary breast lesion that is a NET is still hotly debated, and certainly there as well, one needs to make sure you're not looking at a metastatic GI NET to the breast. The two new kids on the block, mainly for histopathologists to note, is that of a mucinous cyst adenocarcinoma that can look a lot like metastatic mucinous cancer from other sites, such as the colorectum.